Hello, this is Yasser Janab and Huma Qadarian presenting the topic Transcatheter Pulmonary Valve Implantation Native Pulmonary Valve. The rate of morbidity and mortality related to pulmonary regurgitation and pulmonary stenosis are big concerns after the surgery for congenital heart disease. Percutaneous pulmonary valve implantation has been established as a less invasive technique compared to surgery with promising results according to long-term follow-up of the patients. Indications for PPVI are the same as for surgical interventions on pulmonary valve, with limits related to the maximum diameter of available percutaneous prostheses. The indications are symptomatic patients with moderate to severe pulmonary regurgitation, asymptomatic patients with moderate to severe pulmonary regurgitation and right ventricular dilation, and asymptomatic patients with moderate to severe PR and ventricular arrhythmia. Percutaneous PV implantation offers a minimally invasive method to treat RVOT or pulmonary trunk dysfunction in children and adults by restoring acceptable RV loading conditions, avoiding open-heart interventions. There are different transcatheter pulmonary valve implantation options. As you can see in the table, Melody valves, Edwards, Harmony valves, Venus P valve, and Ultra are different options. There are only two approved valve options for percutaneous pulmonary valve implantations until now, which are Melody and Sapien valves. Both valves have limitations and do not cover entire patient population. Therefore, the cardiologist needs more options to improve outcomes with fewer complications in such promising area. Herein, we present a case applying for pulmonary position in native pulmonary valve of a new transcatheter valve system MyVal, which is designed for transcatheter aortic valve implantation procedures. Our case is a 58-year-old man who had undergone surgery for tetralogy of fallot total correction and pulmonary valvotomy 44 years ago, came in with a complaint of shortness of breath. Transthoracic echocardiography showed normal LV size with ejection fraction of about 45%, mild to moderate TR, pulmonary artery pressure of 42 millimeters of mercury, severe pulmonary regurgitation, and moderate RV dilation with mild systolic dysfunction. The preoperative evaluations are surface electrocardiogram and 24-hour Holter electrocardiogram monitoring to detect arrhythmia and define QRS duration. Echocardiography is the first screening tool in these patients. Cardiac MRI, providing that it is not contraindicated, is the gold standard to quantify PR and RV volumes and function. And CT scan is performed in complex anatomy to evaluate the relationship between the pulmonary trunk and the aortic root to assess coronary anatomy and RVOT size. An accurate per-op evaluation is of paramount importance to select patients who could benefit from this procedure. You can see our evaluation with CT angiography and remain show in this patient. PPVI is usually performed under general anesthesia. Peripheral femoral venous and arterial accesses are obtained. Periprocedural intravenous antibiotics are administered and intraprocedural intravenous heparin is recommended. Positioning a stiff guide wire into one of the right distal pulmonary artery branches. Angiographies of the RV and pulmonary trunks are performed in this patient. Measurements are made of the minimum diameter, the largest diameter, and the length of the landing zone in AP and lateral views, as you can see in these two images. To choose the best valve size, balloon waist, or a complete RVOT occlusion by the balloon itself, evaluated with simultaneous RV angiography, which showed in AP and lateral views in patients, as you can see in these two images. To enable precise measurements of the native RVOT and to test possible coronary artery compression, a balloon interrogation was performed with simultaneous selective left and right coronary angiography or aortography, as you can see in this video. Valve implantation is showed in this video. Our valve was MyVal 27.5, which was implanted in AP and lateral views, as you can see in this video. Bioprosthetic PV with no gradients and with no power leakage was the result. You can see in this video in AP and lateral views. After the procedure, and antiplatelet therapy is prescribed for 6 to 12 months in this patient. In summary, PPVI can be a valid and safe alternative to surgical interventions in patients that usually face surgery more than once in their lives. MyVal is clinically feasible for use in the pulmonary position. Further follow-up required for the assessment of the valve efficacy in long-term period. Thanks for your watching.